All right, you guys, let's talk a little bit about the immobilized child. There are some physiologic effects that we'll see with the immobilized child. We'll see a significant decrease in muscle size, strength, and endurance. We can see bone demineralization, which could lead to osteoporosis. And we could also see contractures and decreased joint mobility. Some physiological effects, loss of physical activity, diminished environmental stimuli, sensory deprivation. We could also see isolation, boredom, helplessness, sluggish intelligence, decreased communication, disorientation, hallucinations, depression, and regression. And we also look at the effects of the immobilized child on the family, care coordination, home care, respite. We talked a little bit about this when we were talking about our kids, if they end up in a wheelchair, about the structure of the home, what changes, modifications need to be made, and then of course transportation as well. A good rule of thumb when the child is less willing to bear weight on an extremity, like if they take a fall and we're worried about did they break their leg, did they break something, again, a good rule of thumb is if the less willing they are to bear weight on that extremity, the more serious the injury. Some of our nursing care for immobilized children in general is positioning for comfort, a minimum every 2 hours. We worry about DVT prophylaxis. We worry about nutrition, hydration, and again, anytime we talk about nutrition and hydration, make sure that we're allowing the child to make their selections. Hopefully we can include some of their favorites, but make sure they're appropriate choices. We worry about elimination. We worry about skincare. We worry about diversional activity, schoolwork. Can we get them into the playroom, and what activities can they do in the playroom? Range of motion, physical therapy, promoting self-care. We want them in their own clothes when they're going to therapy. Give choices and explain reasons in simple terms. Make sure we're involving families, sibling visits, support, and allow the kids to express their feelings. Make sure that you are checking their pain level. And then you're going to hear me talk about a neurovascular assessment throughout the rest of this lecture. Anytime I say neurovascular assessment, you guys should be thinking, are they having any pain? What sensation are they feeling? Any numbness or tingling? What's their skin temp? What's their skin color? What's their cap refill? How are their pulses? Can they move their extremities? And is there any edema in those extremities? So that's some nursing care, just general nursing care for a general child with anything that immobilizes them. Traumatic injury. We see soft tissue injuries such as contusions, dislocations, sprains, and strains. And I'm sure you've all heard that these soft tissue injuries are actually more painful and longer to recover from than an actual break in a bone. If we're seeing any of these injuries come in, the therapeutic care management for them is your acronym RICE. Rest, ice, compression, and elevation. And then, depending on if there's any allergies, what's the age of the child, any other disease processes going on, we usually will recommend acetaminophen and or ibuprofen for comfort. Ibuprofen would be for the comfort, will be for swelling, and acetaminophen will be for comfort. And a lot of times we can give both of those together for older kids. It helps. All right, now let's talk about some specific reasons why they could be immobilized. Fractures is one of the big ones. We can see when there's a fracture, there is a epiphyseal injury, which may result in altered bone growth. Fractures can either be casted, or we could have them in traction, or we could see both. When there is a fracture, the types of fracture are bend, buckle, green stick, complete, spiral, periosteal, hinge, all different types of fractures. You don't really need to get into the definition of all those fractures. Just know that there's different type of fractures that exist. A spiral fracture is what we see more often with abuse. When a bone is fractured, we worry about bone healing and remodeling. The diagnostic evaluation that we use to determine if it's a fracture, we listen to the history and also get an x-ray. Fractures heal quicker in children due to a thickened periosteum and a generous blood supply. Neonates, if they would have a fracture, and don't forget, it's pretty hard to give a neonate a fracture, but if they would have a fracture, it could heal within 2 to 3 weeks. Adolescents, they typically heal within 8 to 12 weeks. Just a few things about fractures before we move on to cast. Before we deal with the fracture itself, we need to do our emergency care checks. ABCs, airway, breathing, circulation, vitals, pain, neuro status, neurovascular status. Keep them in a supine position, stabilize the area, get it elevated, and apply some ice to it. We do worry about, with a fracture of a big long bone, like maybe your femur, we worry about a fatty PE, a fatty pulmonary embolism. So be on the lookout for those, again, with long bone fractures. And with a fatty PE, they'll complain of chest pain, shortness of breath. We want to make sure anytime they're complaining of that, we would want to give them oxygen to help keep those alveoli open. So help keep the breathing going so we circulate. Simple fractures, usually we don't have pins with those, but more compound fractures, you could see pins and a cast and traction. So we'll kind of talk a little bit more about pins when we get down to traction. First thing we need to talk about is the care of the kid in a cast. All right, cast, we want to keep them uncovered to allow it to dry completely. And we want to make sure we're turning the child every 2 hours. First and foremost, what material are we working with? Some casts dry quicker than others. If it's a fiberglass cast, it'll take a little bit longer to dry. So just make sure you know what type of cast is put on and then detail your directions for that. You would want to handle the cast with the palms of your hands when it's wet. We don't want to indent it with our fingertips. Elevate the casted extremity. You want to make sure you're checking for the cast. Is it too tight? Is it too loose? This is where our neurovascular assessment comes in. If it's an open fracture, it could require a dressing change and observation of the site along with the cast. Pain management, environmental adaptations, car seat, diapering. If you're looking at the different types of fractures kids can have and the different types of casts, the big one here is the hip spica. It's the cast on the hip areas down the leg, and there's like a T-bar between both of the legs. So when you see that picture, I want you to think about, how am I going to get this kid in a car seat and diaper modifications? Probably not getting that kid in a car seat. The kid will be unrestrained or not restrained in a car seat going to doctor's visits. It's just not, you just can't do it. Do we need a sling to keep the extremities supported? Do we need an overhead trapeze to assist them? Making sure you're assessing for warmth and or hot spots around that cast. And don't forget, when the cast has been on a little bit, they start to itch. We want to make sure that kids aren't scratching. Again, kids get a little creative. Make sure they don't put anything down their cast to help scratch or to hold toys in. We can use ice on a cast the first 24 hours. Make sure you're educating parents on pain and neurovascular checks. What are they doing at home? No lotion down the cast, and the cast should be elevated for 24 to 48 hours if we're sending them out of the ER with the cast on. So just make sure you're giving the parents some good information as well. All right, let's talk about the child in traction. What's the purpose of traction? It is to reduce muscle spasms, position the bone ends to promote healing, and immobilize the fracture site. We want to make sure we maintain traction and body alignment, prevent skin breakdown, and provide pin care. If the child is in traction, they're obviously staying in the hospital. They're not going home in traction. So make sure we have an air mattress on. Think of all those comfort measures we can do for a kid who is immobile. Making sure we're doing our skin assessments, preventing skin breakdown, and cleaning the skin well. To prevent complications, neurovascular assessment And then think about what other complications from being immobilized. What do my lungs sound like? How are my bowel sounds? Am I eating? Am I on pain medication? Am I taking hydration? So think about all of those things when it comes to constipation. If the child complains of pain or being uncomfortable, you can realign them when they're in the bed. Don't forget, as nurses, we never release that traction. That is up to the doctor to do. And make sure when you're looking at the pictures of traction, there's weights hanging on the end of the traction, and that's what's maintaining it. Those weights should never be resting on the ground. If they're on the ground, it's not providing any traction. So make sure the weights are off the ground and we never release the traction. We already talked about the skin, any redness, any swelling, any drainage, any odor. Don't forget about the unaffected extremity, range of motion, our DVT prophylaxis. Simple fractures with traction, there would be no pins. So make sure, remember we said that simple fracture, they're casted, they can be in traction, but there's no pins. If it's a complicated fracture and they're in traction, we're gonna have to make sure we're doing pin care. So assess the areas around the pins, keeping them cleansed, and doing all of that is needed. All right, I think the next thing on here would be an amputation. Amputation is a congenital absence, traumatic loss, or a pathologic condition that led to the extremity not being there. Our nursing care for amputations really is focused on stump shaping. We use a figure-8 bandage, and we do that again to shape that stump to get it ready for a prosthesis. Figure-8 bandages also help decrease edema, control for hemorrhage, so hypovolemia. And again, we're promoting the contour for weight bearing in the future. That's what we need, that contour for our prosthetic. Strengthening exercises of the remaining limb and all the other muscles, good skin care. Don't forget, with an amputation, they could complain of phantom limb pain, and we'll actually, in our very last part of it, I want to say we talk about Ewing sarcoma. I'll talk about phantom limb pain a little bit more there because the treatment is getting their extremity amputated. Don't forget some of the complications with an amputation could be compartment syndrome due to pressure that compromises circulation. We could have neuromuscular damage within 4 to 6 hours, increased pain without relief, intense pain when passively moved, numbness pain. Don't forget with compartment syndrome and with anything, we just continually need to assess. You're looking for any complications. The other thing that we could see with bones is osteomyelitis, an infection within the bone, and they could get this secondary to a bacterial infection. So making sure that we're on the lookout for that as well. And again, with infection, what's our temperature doing? What's our heart rate doing? What's our respiratory rate doing? And what's our WBCs doing? And then that will guide us further. But those are the first 4 things that we're looking at when we're worried about infection.